Well, good morning, everybody. It's nice to see you on Grand Rounds Foggy Morning Edition. Glad to have you all here. And we're excited to welcome not one, but three speakers this morning. We have the heroes of antimicrobial stewardship here to talk to us, which include Nick Stucky. Nick completed his medical school and a PhD at the University of Kansas, and then residency and infectious disease fellowship at OHSU. Brian Kendall, who completed medical school at University of Washington, is that right? And then he was a resident right here with us at PPMC, and then did his infectious disease fellowship at the University of Utah. And we also have Brent Footer with Department of Pharmacy, who completed his pharmacy training in Buffalo, and then a residency in San Francisco and infectious disease pharmacology in Buffalo. And we're so glad they're here to teach us how to be better stewards. Welcome.
Thank you, Jesse. I'm Nick Stucky. I'll be starting off, and just want to say thank you for having us. This title, don't worry, it's not like part 4, like you missed the first 3 parts. This is sort of an attribution to Jim Leggett, who's done this work for a long time, and many of you guys probably know him. You know, without him, I think in part we wouldn't be leading in this area as we are today. Our disclosures, no disclosures other than Brian Kendall has a grant from Merck. The outline of our talk, so I'll be talking a little about where antibiotic resistance comes from, the history of AMS here at Providence, Portland. Brian will be reviewing some of the literature and talking about things we can do to help sort of push back against development of resistance. And then Brent will be talking specifically about the program here at PPMC and what we're doing as a program to help all of us help our patients. So the timing couldn't have been better to come see you all. Next week is US Antibiotic Awareness Week. I was wondering why they picked that week, and I thought, well, maybe it has something to do with the fact that on a sort of per kilogram meat production, turkeys are actually the most antibiotic intensive livestock to raise. So hopefully now, when all of you are sitting at your Thanksgiving dinner tables, you'll be thinking of antimicrobial stewardship. All right, so starting off with a case that was seen here at Providence, Portland. This was a 71-year-old female who was previously healthy, who came in with acute onset abdominal pain and nausea and vomiting. She was diagnosed with pancreatitis. She had quite severe disease. She was in the ICU. She was on pressor. She was started on Pip/Tazo. And did a little better, but had a persistent leukocytosis, so she was brought into meropenem. Eventually that was stopped, but then due to some imaging that showed probable development of a pseudocyst, she was placed back on broad-spectrum agents. And it wasn't until week 6 when she was discharged on oral antibiotics to sort of treat these persistent fluid collections. She returned the next week and was having weakness, again, put on broad-spectrum agents. Imaging showed a maturing pseudocyst. And it wasn't really till week 9 that they sort of, attempted source control with a cyst gastrostomy. That showed purulence, and the culture grew out Pseudomonas. And at that time, Pip/Tazo was stopped and cefepime was started. And that was a result of this susceptibility panel. And you see, Pip/Tazo is intermediate here, probably reflecting the fact that she'd been on Pip/Tazo for several courses of Pip/Tazo over the previous 6 weeks. Another, I think, pertinent aspect to this case is that she had a sort of a large burden of disease, so that she had a 22 by 8 centimeter abscess. And so, again, this wasn't drained right away. She was on antibiotics. When we see a large abscess, we worry that that's a lot of bacteria, and that's a increased opportunity for spontaneous mutations to sort of develop into resistance. So it's basically more opportunities to develop resistance. I should also say that Pseudomonas is one of those bacteria that we fear. It's got a lot of tricks, and one thing is it has a lot of virulence factors that make it potentially develop into severe disease. But the other thing more pertinent to this talk is it has many resistance mechanisms, and so it can, in this situation, has high potential to develop resistance. So moving back to the case, it was on week 11 she was transferred here for further surgical care, and on admission here, she was started on meropenem. Shortly thereafter, or I should say a week thereafter, a drain was placed and again grew a Pseudomonas. And that same week she had a necrosectomy, again another attempt at sort of source control and getting some of that bacterial burden decreased. And so now the profile, susceptibility profile looked like this. Now she has a Pseudomonas that's resistant to cefepime, again probably reflecting the fact that this bacteria had seen a lot of cefepime. So eventually she improved, meropenem was stopped, but then she had again this persistent leukocytosis, so she was off and on meropenem for the next few weeks, and eventually improved enough that she was able to be discharged. But much like previously, she was back the next week and again started on meropenem. A drain was placed, the culture came back with Pseudomonas. Does anybody care to venture now what the susceptibility panel might have shown? So not too surprising, now we have a meropenem-resistant Pseudomonas. And so again, just reflecting prior sort of exposure with this large burden of disease. So back to the case, again, she improved, stopped antibiotics, and at this point with the susceptibility profile, we requested susceptibility to ceftolozane tazobactam, which is a newer beta-lactam, beta-lactamase inhibitor that's sort of engineered for Pseudomonas, and it was susceptible, so we put in the process getting some of that drug here at Providence, Portland. And then the next week after that, her drain became clogged again. She developed hypotension. She was started on that agent that we had obtained, and unfortunately, overnight that night, she developed severe abdominal pain. Her imaging showed free air, and she was placed on comfort care and passed and died the next day. So I think this case, this unfortunate case, highlights some key components here. We had a large burden of disease that was around for a long time, an organism that can develop resistance that we know is quite facile at employing different resistance mechanisms. And then we had a lot of antibiotic pressure, so antibiotic for a long time period. So that's the case. Stepping way back, where do these resistance genes come from? So where do these Pseudomonas develop these resistance genes? And the hypothesis is that this is a result of evolution, billions of years of evolution, as bacteria, most likely in the soil, have been competing with each other, and there's been this sort of ongoing bacterial warfare with measures and countermeasures developed for survival. And so the bacteria have developed antibiotics, and they've also developed antibiotic resistance genes. And this was further sort of supported by a recent publication where the authors went to a remote area of Antarctica. They took deep core ice samples, so deep that what they were finding were frozen bacteria that had been frozen since long before man was using antibiotics. And they ran these samples and looked at the DNA there. And what they found was antibiotic resistance genes. They found resistance genes to aminoglycosides, to chloramphenicol, to beta-lactams. And so this kind of reinforced the fact that these genes have been there for a long time, and again, result of that long-term evolution bacteria. And what we also see is, some of this evolution or emergence of resistance has probably sped up in modern times as we've started using antibiotics. So this is a timeline from the CDC. On the top, it shows when antibiotics were introduced, and on the bottom it shows when antibiotic resistance emerged to specific antibiotics. And some antibiotics have taken longer for resistance to develop, but I think a good example here is levofloxacin in 1996. The same year that it was introduced, we identified levofloxacin-resistant pneumococcus. So this is something that can potentially happen quite quickly. So how bad is the problem? How ubiquitous is the problem? This is, I think, another interesting study that was done in 2018. And in this study, the authors went around to major cities around the world. And they had, I think, the quite ingenious experimental plan they collected car air filters. So these were cars that were driving around these cities. They collected the car air filters, they took them to the lab, and they dumped out all the particulate matter that had been sitting in those car air filters. They isolated the DNA and amplified it, looking for antibiotic resistance genes. And what you can see here on the left is they found abundant antibiotic resistance genes. You can see the warm colors indicating higher abundance and the cooler colors indicating lower abundance. And they found them in all these major cities. They found all the different antibiotic classes represented. On the top right, that figure just shows that there was a diverse set of antibiotic resistance genes. So in these cities, there were antibiotics genes targeting pretty much all the major classes. And then in the bottom right, one thing that they did interestingly is they sort of roughly correlated the presence of these resistance genes to the global use of antibiotics. So you'll see on the top right of that bottom right figure that there's beta-lactamase genes there. And the beta-lactams are the most commonly used global antibiotic subgroup, basically. So resistance genes and their abundance is correlated nicely with our use of antibiotics on a global scale. One thing that I didn't show here that also I think is interesting is they got car filters from 2004 and compared them to car filters from 2014. And they showed, even with normalization, they showed increased abundance of these genes, so indicating an increase over that decade. So what's driving all this resistance today? Well, I would be sort of remiss to not bring up the fact that antibiotics are used in livestock. The FDA earlier this sort of decade looked at the resistance genes and looked at what percentage of antibiotics were used in farm animals. And they found that their estimate was about 70% of antibiotics used in this country were used in healthy animals. That resulted in the FDA banning the use of antibiotics in healthy animals in 2017. You can see this is a package insert for a commonly used tetracycline. And you can see there as one of the indications on the package insert, it says, for increased rate of body weight gain and improved feed efficiency. So those are the uses that have since been, that they're trying to regulate and push out. But you can imagine the problem is A, unknown, and B, probably worse in countries that are less regulated than ours, places where we often do import meat. And then it's also predicted that as the global demand for meat is rising, and so as that rises, so is probably the use of antibiotics. So stepping a little bit closer to what we're doing and how we're contributing to resistance, well, in a word, it's overuse. We're overusing antibiotics. The CDC has been tracking this for a long time. This is a map of sort of a density of where courses of antibiotics are prescribed and with what intensity. And so you see there's some variation across the United States. But on average, well, I should say, we use 266 million courses of antibiotics annually in this country. So that's an antibiotic course for 80% of the US population every year. In Oregon, you can see, so the deep red are higher intensity of use, and then the lighter colors are lower. So we're on the lower end, but we're still at about one antibiotic. In Oregon, we're at one antibiotic course for 50% of the population every year. So, can we do better? Well, probably, because the studies have also shown that about 30% of antibiotic use is unnecessary, meaning it's not even needed, no antibiotic is indicated. Additionally, there's another 20% of use that is probably inappropriate, meaning the wrong antibiotic, the wrong duration, the wrong dose. And so, this is a problem and something that's probably driving resistance. So how do we hope to sort of impact and change our prescribing practice? Well, that's really where antibiotic stewardship comes in. And the goal is really to use tools to help us find the right drug, the right time, at the right dose, and the right duration. And so on a national scale, the way that this has been implemented is, the CDC has had for about a decade strong recommendations around what an antimicrobial stewardship program should look like. These sort of central tenets are like hospital leadership commitment, accountability, drug expertise, so pharmacy involvement, action in terms of implementing projects, tracking so that those projects are data-driven, and then reporting up to the national level so that there's an understanding of, on the national scale, what's happening. And then finally, education like this talk we're all doing here today. And those are kind of the central tenets. Recently, just in September of this year, the CMS came out with guidance requiring all hospitals to have an active antimicrobial stewardship program. And we've been kind of ahead of the curve here at Providence, Portland. In '89, we started doing daily blood culture surveillance. In '92, rolled out order sets to help with antibiotic dosing. Since 2002, we've had weekly antibiotic stewardship rounds with the pharmacists in the hospital. And then throughout all of this period of time, there's been ongoing education to prescribers. And as a result, we, in part due to fortuitous geography, but in part due to the work of all of our predecessors, we have an antibiogram that looks like this, green representing susceptible organisms. So there's a lot of green up there on this antibiogram. And obviously, we'd like to keep it that way. But we're also faced with, this is kind of the global and national reality. So this is a specific carbapenemase producing organism, so a resistant organism, showing its spread over 2 decades in the United States, starting very localized in Virginia and in the Northeast in early 2000s, and then more recently now it's pretty much everywhere. So much like the march of time, the resistance just sort of marches on and spreads, and so we hope to sort of push back against that. And hopefully I've kind of showed you the scope of the problem here. Dr. Kendall is now going to take over and discuss hopefully some simple things we can do to sort of push back against this and help protect our patients.
I'm going to try to use this microphone. Sounds like it's working. So thank you, Dr. Stuckey, for kind of showing us the origins of this problem. I want to talk about a mantra I'm hoping that you will all embrace, that I think is something we can all do locally in our day-to-day work to improve the situation, and that is the mantra of shorter is better. Avoiding unnecessary antibiotics is important. It's often a difficult task, especially in inpatient units where there's pressure to get antibiotics into a patient quickly. Narrowing antibiotics is also important, but I think the safest and most important target for reduced antibiotic use currently is duration. We need to be using far less antibiotic than we do, even when we do use it. This was really beautifully discussed with this by this editorial from Brad Spellberg and Lewis Rice. It was published this year in the Annals of Internal Medicine. Shorter is better. So I'm stealing their phrase and some of their guidance here. Just a little bit. So in this editorial, they refer to the often used duration of antibiotics in multiples of 7 with the following quote: "The definition of a week was decreed by Roman Emperor Constantine nearly 2,000 years ago. This seems an unsatisfactory evidentiary basis for modern medical practice." So other than pithy quotes, what does this editorial offer us? And I also have a figure of the other evidence base for 5- and 10-day courses of antibiotics. Spellberg looked at all 45 recent randomized controlled trials comparing short versus standard dose or standard duration courses of antibiotics. In all 45, there was no difference in efficacy between shorter and longer courses. And in fact, in the RCTs that evaluated the development of resistance, they found that shorter courses led to less resistant bacteria when they looked at what was colonizing patients' respiratory secretions. Vaughn et al. Looked retrospectively at 6,500 adults admitted to hospitals in Michigan with community-acquired pneumonia and found that there was the risk of adverse effect actually increased by 5% per additional day of antibiotics. That is a number needed to treat of about 20 for 1 extra day of antibiotics. We all know that when we overuse, it's not usually 1 day. So we are clearly causing adverse effects with overuse of antibiotics. It's somewhat intuitive, but not something we think about often, but each day beyond the first, you have a decreased benefit from your antibiotic use with an increased risk. And of course, at some point, those lines cross. And what these authors found is that in CAP, those lines converge and cross at about 3 to 5 days. So think about that when you're tempted to do a 10-day course of antibiotics. So I'm going to spend most of my time looking at some of the guidelines and evidence base for specific diagnoses that we see here frequently at PPMC. Community-acquired pneumonia, hospital and ventilator-associated pneumonia, UTI, intra-abdominal infections, skin and soft tissue infections. Hospital-acquired pneumonia and VAP guidelines were published in 2016, the most recent iteration. And they looked at durations of treatment of what they called short course of 7 days versus anything longer than that was a long course. They reviewed 2 systematic reviews totaling about 1,400 patients, and then the authors of the guidelines performed their own meta-analysis, so 3 studies. They found no increase in mortality or other negative outcomes in shorter course therapy. One of the 3, but not the other 2, found an increased risk of recurrence in patients with Pseudomonas aeruginosa. So the guidelines support 7-day durations for HAP and VAP, maybe longer for Pseudomonas aeruginosa, but that is still to be determined. So I'm mostly going to speak about duration. I do have a few digressions because I can't help it on spectrum of coverage. So one of the problems with the previous iteration of these guidelines was that if you had even met a doctor once in your life, you were considered healthcare exposure, and you were given multiple antibiotics to cover for multi-drug resistant organisms. Since those guidelines were published, there's been a lot of new evidence that really has narrowed in on the major risk factor for MDRO infection, and that is receipt of IV antibiotics in the previous 60 days. So these are really the patients who should be considered to have broader coverage empirically. The community-acquired pneumonia guidelines were just updated and published last month. These guidelines suggest we treat for no less than 5 days and until clinical improvement. They reviewed multiple trials comparing 5- and 10-day courses of antibiotics and found no difference with these antibiotics that we frequently use for CAP. They did kind of punt to the HAP guidelines for MDROs and said 7 days for MRSA and Pseudomonas without strong evidence. These guidelines do lead to a little bit of controversy. They specifically advise against treating for less than 5 days, while acknowledging that most patients will actually achieve clinical stability within 48 to 72 hours. I just forgot to put this in here, but I can't help but tell you about it. There was a trial for daptomycin, a gram-positive antibiotic that we do not use for pneumonia because we have since found that it is inactivated in the lung by surfactant. But before we knew this, there was a pneumonia trial in which the daptomycin patients actually did quite well because they received less than 24 hours of an active agent before the daptomycin. So clearly, some patients do well with a single day of antibiotics, and I'm quite confident that not everyone needs 5 days. Hopefully, we'll have some more evidence base for that in the future. Another point of controversy is the authors advise against the use of procalcitonin for deciding to withhold or discontinue antibiotics. I think if anybody has been here to see Dave Gilbert speak, they will realize that there is abundant evidence for the use of procalcitonin to reduce durations. And Dave has written many useful editorials for us, if you want to take a look at those. Another digression on spectrum of coverage. In the CAP guidelines, they also acknowledge recent IV antibiotics as the major risk factor for MDROs. They also say if you've had an actual infection or colonization with MRSA or Pseudomonas, that is in the last year, that's another reason to consider broadening therapy. The MRSA nasal swabs we use here have excellent negative predictive value. So if you have a negative nasal swab, you do not need to cover for MRSA and pneumonia. And the last point that I really hammer the residents with is that additional anaerobic coverage is not recommended in the guidelines just because a patient aspirates. Our usual coverage gets those bugs just fine unless you have an abscess or empyema or a large burden of anaerobic bacteria. So cellulitis, and again, everybody who's rounded with Dave Gilbert knows that it's actually erysipelas we're usually talking about in this situation, and it's really the term we should use. I had to actually look this up, I'm embarrassed to say. I didn't know what the guidelines were for duration, but the IDSA guidelines, which are not new for this condition, suggest 5 days of antibiotics, but suggest that you can extend based on clinical response. I would like to point out that we all have an important role in clinical response beyond antibiotics, and that is elevating patients' legs, dealing with edema. I had a patient just last month who, when we rounded early in the morning, everybody said his cellulitis wasn't better. Then he would get up and walk around the unit all day, and if people saw him in the afternoon, they decided his cellulitis was worse because of the venous stasis. So get those legs elevated above the patient's heart. If you're treating erysipelas, cefazolin really is all you need reliably. Occasionally we use clindamycin for very ill patients with a lot of toxin production, and that's probably a better broadening strategy than broadening to vancomycin and zosyn if a patient does not have a very quick response. Another thing I think we all need to do better about as doctors is avoiding using the term cellulitis and grouping conditions together like wound infections, diabetic foot infections, and abscesses, because these conditions really do have a different antimicrobial spectrum. You may need that gram-negative coverage, so you can actually avoid a call from us if you want to continue zosyn when you actually are treating a wound infection with lots of green purulence rather than erysipelas. The STOP IT trial, which is a fantastic trial name, the study to optimize peritoneal infection therapy. This study was performed by a large surgical group who acknowledged that guidelines even years ago recommended 4 to 7 days, but that typical courses were longer, usually 10 to 14 days for intra-abdominal infections. So they randomized over 500 patients. Importantly, all had had attempts at source control, and they were randomized to either 4 days of antibiotics or to resolution of inflammation plus 2 days. What this turned out to mean was 4 versus a median of 8 days of antibiotic therapy. They found no difference in their composite outcome of surgical site infections, recurrent abdominal infection, or death. Both groups actually had a high rate of the composite outcome of 22%, but the authors acknowledged that this was largely due to source control. And in fact, it was better to fail earlier than later because you can control your SIRS symptoms for a long time with antibiotics, but it doesn't actually make the patient better until you get source control. So this trial was very welcome, and we've actually seen it documented in lots of surgical notes now, and a nice drop in antibiotic use in this population. Urinary tract infections. So we have data as far back as 1995 that for complicated UTI, 7 days is as good as 14. More recent studies have demonstrated that even for pyelonephritis, that 5 or 7 days is as good as 10 or 14 days. And we are clearly treating much longer than this on a routine basis. I'd also like to point out that the use of the term complicated UTI has become very nebulous and can mean anything from a patient with diabetes to heart failure. Really, when we think about complicated UTI, we should be thinking about urologic complications, the presence of hardware, presence of abscess, abnormal anatomy, prosthetic material, not anybody who's ill. I know I said duration, but there are really some indications where even in the inpatient group, we should not be starting antibiotics at all. We've known for a long time that treatment of asymptomatic bacteriuria does not decrease the risk of UTI. And in the last few years, we've had several studies that showed us it actually increases harm. So Kai et al. Looked at almost 700 premenopausal women and found that in the group that was treated for asymptomatic bacteriuria, it's a hard word to say, 47% developed UTI subsequently versus 13%. That is a huge number a huge amount of harm for treating asymptomatic bacteriuria. They did a follow-up study looking at the resistance spectrum and found that the patients who were treated and got UTI then had more resistant bacteria, not surprisingly. We've been waiting for a similar study in the postmenopausal patients that we see admitted to the hospital, and we got something like that just this year in JAMA Internal Medicine. They looked at 2,700 hospitalized adults with asymptomatic bacteria with a median age of 77, and found that the only difference in outcome between those that were treated and those that were not was actually a longer hospital stay for those that were treated. No other negative consequences of not treating. So we need to protect our patients and not expose them to antibiotics for this condition. The IDSA guidelines recently updated for asymptomatic bacteria, and one of the few remaining indications for treatment of asymptomatic bacteria has been having a renal transplant, but that has now changed so that after the first month post-transplant, you should not treat asymptomatic bacteria, even in this immune-compromised group. Last slide for me. So we use a lot of anti-pseudomonal antibiotics empirically for sepsis, but this also has the potential to cause harm. So a recent study found that when piperacillin and tazobactam were used in the ICU, you actually increased the risk of colonization not with piptazo-resistant Pseudomonas, but with carbapenem-resistant Pseudomonas. We know that from other large studies that the increase in the development of resistance increases about 4% per day when you use anti-pseudomonal antibiotics. And this last study was pretty dramatic to me, that at 48 hours, the risk of C. diff infection increases threefold when you're using anti-pseudomonal antibiotics. So if Dr. Footer calls you and says, you know, you probably could narrow from piptazo to amsulbactam, that is not an inconsequential recommendation, and you could be preventing C. diff or other bad things in your patients. So with that, I will hand over to Dr. Footer, who's going to tell you how our program is structured and works and what we're doing to help you with these issues.
All right, thanks, Brian. So as Dr. Kendall was saying, one of the ways to reduce antimicrobial resistance and not adversely affect our patients is a shorter duration. But another strategy to do that is to have a robust antimicrobial stewardship program. And so even though we've been doing antimicrobial stewardship here at PPMC for almost 3 decades, it wasn't until August of 2018 that we actually had dedicated physician and pharmacist time to tackle this problem. And as we were setting out with our group and organizing ourselves, we asked the question, you know, why do we exist? What is it that we want to achieve? And we want to ensure that every patient that receives an antimicrobial receives the right drug at the right dose and for the right duration, while limiting medication adverse effects and decreasing the emergence of resistance. We then further went on to ask the question of, what do we want to achieve? What does this look like in the future? What do we aspire to be? And we want to implement meaningful interventions that improve patient outcomes and quality of care. We want to be available to staff as frontline resources for both infectious disease complications as well as antimicrobial stewardship. And we want to give clinicians and decision makers data so that they can have and make informed decision making. So as I think about this, how do you improve quality of care and patient safety? There's a lot of things that go into that. I tried to boil it into 3 main topics, which is action, tracking, and reporting, as well as leadership. So under action, we have things like prospective audit and feedback, antimicrobial restriction, protocols, order sets, education, all of that. Under tracking and reporting, we look at resistance, we look at our antibiotic utilization, and we look at patient outcomes, length of stay, readmission, C. diff rates, all of that. And leadership really comes from the day-to-day operational things that comes from our physicians and our pharmacists, and it also comes from both regional and system support from our executives. So within Oregon, this is just taking a high-level view of our structure. So it's broken into an East and West region. Dr. Kendall is the physician lead for the East region, with Dr. Stucky being the PPMC physician lead. And I'm the pharmacy lead over the entire region. So I want to draw your attention really down to PPMC. And what we've tried to do is engage key stakeholders along the way ranging from critical care to hospitalists, surgery, medical education. And we met with all of those people and we said, what are antibiotic problems that you see? How is this utilized in your practice? And what interventions would be meaningful to you and help you use antibiotics better? We got a lot of feedback from that, not surprisingly, and I think you'll go on to see later in the presentation some of the projects that have come out of that. We also, of course, set up some goals and metrics, and this is just a sampling of them. I'm not going to really drill down and go in depth other than to say that we have a focus on fluoroquinolones, especially in uses that I consider never indications like UTI, sinusitis, and bronchitis. We're also heavily focused on skin and soft tissue infections, and that's really harkens back to Brian's point about cellulitis or erysipelas and not treating with broad spectrum gram-negative agents. So this is looking at patients on, Zosyn, cefepime, things like that. And then we're also have a goal of reviewing all positive blood cultures in real time, and I'll talk about that a little bit later. So really the nuts and bolts of our antimicrobial stewardship program centers around this daily huddle. So every day there's an ID physician who's assigned to the antimicrobial stewardship program, as well as a full-time pharmacist. So we meet to discuss patients, and our patients come from a number of areas. They could be targeted antibiotics like fluoroquinolones or carbapenems, selected disease states like pneumonia or UTI, skin and soft tissue infection. We also get physician referrals throughout the day, so many people will page us or call us with questions. At PPMC, we go around to each clinical pharmacist and we ask if they have patients that would be appropriate for antimicrobial stewardship discussion. And of course, we're always getting real-time blood culture notification. And so all of that comes together for this daily huddle where, like I said, we discuss the patients, and we make a determination of whether we're going to leave an intervention or not. And so you may have seen these notes in the chart when we do make an intervention, but I do want to point out that there are actually a large number of patients that we do not intervene on. Either we make a determination that we need more information, or that the clinician is making the appropriate antibiotic choices. So I do want to say kudos to all of you out there, because we really actually only intervene on about a quarter of the patients that we actually review. So there's a lot of appropriate use out there. So drilling down a little bit to see what interventions we're making and what types of interventions those are, I was actually a little bit surprised at this. I obviously knew that we would be making a lot of discontinuation and de-escalation. That I think intuitively makes sense, but that's only about 50% of the interventions that we make. So the other half of them is really what I would consider adding to care, either by through an escalation, clarifying an allergy, because we know folks who have penicillin allergies and don't receive beta-lactams do worse. We're ordering diagnostics or recommending increased diagnostics to help clinicians out, or recommending ID consults. So that's actually about half of our interventions, which, like I said, was a little bit of a surprise to me. Our acceptance rate for our interventions is 83%. I don't know if that's good or bad. We feel good about it, considering we're a new program. And I think there's a fine line between intervening in cases that are really obvious and easy to do, and intervening in cases where, it's either a difficult patient to tackle or should really be an ID consult. So we intervene most commonly in pneumonia and skin and soft tissue infection by far. This is the biggest group, almost twice the rate of anything else. And the second biggest group is kind of this lumped together with intra-abdominal, urinary tract, and bacteremia. All of those are intervening on around the same rate. I don't think it's a surprise to anyone who's in the hospital that, our common antibiotics are vanco, piptazo, and fluoroquinolones is what we're intervening on the most. One of the other things that we do, in addition to the daily huddle, is we've developed protocols. So here's an example of our Empiric antimicrobial guidelines. And so this was really started with a collaboration with the emergency room physicians. And then it's sort of spilled over into being a decision support tool for any clinician here. And so it's broken up by disease states. This is just a little snippet of the pneumonia section. And so I want to just point out sort of what this is. So we give a preferred therapy recommendation for both patients who have a penicillin allergy and patients who do not. We give a recommended duration. And then in the comment section, which is this box here, we've tried to tailor that to local sensitivity as well as local risk factors. So if you look at the community-acquired pneumonia with MDRO box, we keep in the guidelines from the IV antibiotic and hospitalization, but we also point out to clinicians that the Pseudomonas and MRSA pneumonia and community-acquired pneumonia at PPMC is super rare. It occurs less than 2%. So we're hoping by providing this kind of information to clinicians that they'll be able to make better choices. And I also should point out that this is, Oregon P&T approved. It currently lives on the pharmacy page, and so it can be a little bit difficult to find, but we're trying to maybe get that out there and be more widely available. So in terms of tracking and reporting, our gold standard is this thing called a day of therapy. Essentially for this talk, that's just a measure of antibiotic consumption. And then we normalize that to 1,000 patient days. And what that does is it allows us to compare across units or across hospitals. Right now, we only compare within the Providence system, but starting in 2020, we'll actually be submitting to a national database, and we'll be able to compare with nationwide. And I can say within Providence, with facilities that are similar sized, PPMC looks very, very good in terms of use. And this graph here, I'm not gonna go into it too much other than to say this is antibiotics by class, other than to say the most commonly used class here is cephalosporins, generation 1 through 3. Again, the most frequently used antibiotics are Vanco, Zosyn, ceftriaxone. Probably not surprising to anybody. Over here on this section of the graph, this is actually looking at our fluoroquinolone usage over 2 years at PPMC. And you can see in November, our day of therapy was around 40, and that's basically dropped down to 20. So we've had a 50% decrease in fluoroquinolone prescribing in 2 years, which is, absolutely, it's pretty phenomenal, actually. And a lot of that was done even before there was a formal stewardship program. So I'm going to switch gears and spend the last couple slides really talking about projects, because I think they're in some ways more interesting than days of therapy. So, this is just a slide that reminds us of all of the steps that need to be accomplished or done when we order a blood culture and before final susceptibility testing comes back, right? So we have to incubate it, gram stain it, and identify it, and then do susceptibility. All of that, takes up to 72 hours. So maybe if you're lucky, by 24 to 48 hours, you have a species identification, and then another day before you have susceptibility. So why this becomes important is rapid diagnostics is taking over infectious diseases. So we're getting more information and more information faster than we ever have before. So what is our lab doing in terms of blood culturing? Well, we're actually going directly from the blood culture bottle to organism identification. And so what does that allow us to do? We now have species level data at, say, 12 to 36 hours. And once you have species identification, you can pair that with patient risk factors and the antibiogram, and you can actually start to make interventions right at that time point. So we're getting patients off broader therapy much sooner, even in bacteremia. So I'll show you some data for that. But before, I want to just say, how does that become a stewardship intervention? Well, numerous studies have shown that you can do all the rapid diagnostics you want. You can have results back in 5 minutes, but if nobody is there to look at them and act on them, you're not going to have an impact on patient care. So, as I mentioned, studies have looked at pairing rapid diagnostics with active antimicrobial stewardship intervention, and they found that reduces antimicrobial usage, length of stay, as well as cost. And actually, it's interesting, the Oregon region had been doing this rapid MALDI blood culture identification dating back all the way to January of 2018. And when we started with the stewardship program, we realized that those results were going in and nobody was using them, or hardly anybody. So what is the intervention that we're doing in this? Pilot study, where the microbiology lab identifies our antimicrobial stewardship team each time a blood culture speciates. We then review the patient and we make necessary recommendations for treatment regarding antimicrobial therapy, and this could be anything from de-escalating to broadening therapy. And our primary objective is to decrease the time to optimal antimicrobial therapy. And so here's some data that was collected by one of our former residents, Maddie Sano, and she's also now a PPMC pharmacist. So I'll draw your attention first down to here. And so what we were able to do is reduce the time to optimal antibiotic therapy by about 2 days. And so I'll give you an example of this. Say Enterococcus fecalis comes back in a blood culture. We know from our antibiogram and from looking at our data that it is almost universally susceptible to ampicillin, over 99%. Many times these patients are on vancomycin, which A, is not as effective, and B, obviously carries risks of toxicity. So what we're able to do in those patients with Enterococcus is pretty much immediately de-escalate them to the drug of choice, ampicillin, which not only improves patient care, but also improves our antibiotic usage. And that's reflected up here in the top, where the length of stay difference in the post-intervention group was actually 2 days less. And we think that happens because you have patients on the optimal antibiotics sooner, they get better faster, they get out of the hospital faster. And then this bottom section really just talks about antibiotic usage, and that was also decreased. Another project that just started that I'm really excited about is our early de-escalation of antibiotics at the transition from the ICU to the ward. And this is a collaboration with critical care and med ed. And we know that intensive care unit patients with infections are initiated on broad spectrum antibiotics. After they stabilize, their antibiotics may not be de-escalated appropriately for a number of different reasons. Oftentimes, it just simply boils down to a change in location and a change of team. So what we've done is we've asked the ICU medical residents to place a sign out into the chart at the time of ICU discharge, which outlines the latest antibiotic plan from the ICU team. And we're trying again to measure decreased days of therapy on broad spectrum antibiotics. And I'll also say the critical care team is using this note to look at lines, drains, and tubes, and also use that to make recommendations so that patients aren't inappropriately transferred out on Foley catheters or with central lines. So in summary, antibiotic resistance is ancient and it's ubiquitous. We know that excessive antibiotics increase resistance. We know that the majority of infections that we treat can safely be treated with courses much shorter than we currently use. Our AMS team is actively reviewing antibiotics in real time, and we are trying to help you, and we really want to empower clinicians to use the right drug at the right dose for the right duration via multiple projects. And I just want to take a second to thank many people who have been involved with the stewardship program, from the microbiology lab to our colleagues on the west side, all of our AMS champions, medical and pharmacy residents. This is tough work, and it takes a village, so to speak, to do it. And so thanks to everybody who's been a part of that, and I'll open it up for questions.
Go ahead.
On the issue of shortened length of treatment, any comments about pregnant women?
The question is whether there's any comments on pregnant women, and no, there are not. I don't know of any specific data. I didn't review any for pregnant women. In conversations with our OBGYN colleagues, I am finding them using shorter courses and sometimes even avoiding treating asymptomatic bacteria even in pregnancy, but I can't tell you the nuances of that.
Quite understand the asymptomatic bacteria. First of all, I don't understand asymptomatic bacteria, but beyond that, it looked like the ones who were treated, how was it that they did worse than the ones who were not? Tell me.
Yeah, Dr. Patterson's asking about treatment of asymptomatic bacteriuria, and basically the idea is that colonization increases dramatically with age and medical illness to something like 90% of nursing home patients will be colonized with bacteria in their bladders. Generally, most of those bacteria will be somewhat benign colonizers, and when you treat it to eradicate it, you're allowing a chance for a new, more virulent bacteria to replace it, and therefore increase the risk downstream of an active infection or a symptomatic infection. So lots and lots of evidence now that that's what happens. If we treat patients who feel fine but have bacteria in their bladder, we actually give them infections down the road. Does that answer your question?
Sure. What about a pediatric population?
Again, pediatrics is not our specialty, so I'm not sure I have a lot of information about that, but I think that, is Genevieve Booster here by chance? Nope. Oh, we do have a pediatric ID doc, Dr. Drummond here. Any thoughts?
Yeah, so, I mean, we generally don't treat asymptomatic bacteria in kids, but it's a whole different population, right? Because they're not in an extended care facility necessarily, so we're not actively looking for those things. Kids will get treated if they have complicated urinary tracts, but even then, like, peds ID is usually actively involved working with urology to really limit those courses.
Thank you, Dr. Drummond. I think, Ron, you were next.
Yeah, great talk, by the way. And can you comment on anything that's happening in terms of decision support in FA to help physicians select the right drug for a patient?
Sure. So there's been a number of things there's a new sepsis order set, for example, that has been rolled out that gives empiric guidelines, and that also has what's really cool about it is it sets the duration. So if you order somebody for community-acquired pneumonia from that order set, it will automatically default to 5 days. There's also a new program that may not be decision support necessarily for all physicians, but I think it will help in AMS and IP. And that's, we're getting this new software that's called Bugsy, and that will allow us, like I said, to report to the national databases, as well as it will allow us to run some real-time antibiograms, which I think is really cool. And we can do that in terms of like unit specific or just looking at urinary tract isolates and things like that. So I think that will add, once those get out there, I think that will add to the physician support. And then there's lots of things like one of the things that helps reduce fluoroquinolones was there's a BPA. If you've noticed, if you ever try to order Cipro for a UTI, it pops up in a big yellow box and tells you don't do this. So that's actually been really helpful, and that BPA is accepted almost 50% of the time at PPMC, which I've heard is a really, really good acceptance rate.
So just to clarify, if someone wants to order an antibiotic and they want to use decision support, it's going to be built into just the sepsis order set?
Well, the sepsis order set. Yeah, the only thing I know of in terms of decision support comes from order sets. They are changing the other blocks, so like the pneumonia order set is going to change to match the sepsis order set, but I don't know that there's something that's going to pop up if you just have cefepime, say, on your preference list. I don't know that there's going to be anything that's going to pop up and say, consider ceftriaxone or something like that, or, yeah, I don't know. Of course, we do have indication that is selected, which helps out. I know they're doing some stuff on penicillin allergies, which is really cool. So I think that they're going to stop showing you those alerts that tell you that somebody has a penicillin allergy for nausea and vomiting. So I think that's going to go away from the physician side, and that's a good thing to try to get people over onto beta-lactams. I don't know when that's going to be implemented, but I know that is a project that they're working on too. Sure.
What about antibiotic use in prophylactic antibiotic use post-joint replacement for dental procedure?
Question was about dental prophylaxis with antibiotics. I think when I was a resident, I actually gave a talk on the new guidelines that argued against that, and I think we've kind of swung back and recognized that there has been some harm. For orthopedic procedures, though, largely the infections are driven by skin pathogens and not mouth pathogens, so it's probably minimal impact, but also low risk of harm with a single dose of peri-procedural penicillin around dental procedures. So we're not going to tackle that one as a goal. Wow. Yes, sir.
Clarify the issue of the step down from ICU to the general ward. I didn't understand whether the orders were changed or whether somebody else had to write it.
Yeah. The question is about the ICU Transfer Project. It's not an order. It is guidance, because typically when patients leave the ICU, they switch to a hospitalist provider, and we've found that because of the complexity of these extremely ill patients, there's often the decision to leave the antibiotics just a little longer while we sort out and get to know this very complicated patient. So the idea is that the people who know the patient best when they're quite ill can give some guidance that's explicit and that says, you know, this patient really only needs 2 more days of ceftriaxone when they leave the unit, and so we don't get 5 more days because the provider is overwhelmed.
In the review of such then, has there been a success in that alone? And if not, why not write the orders from the ICU?
I think the reason we would not write the orders from the ICU is simply because there is a new provider then responsible for the decision-making, and it would theoretically a good idea, but practically getting everybody on board with that would be a whole order of magnitude more complex. But maybe that'll be our next project. Yes, sir.
Post-Foley catheterization, certain percentage, I don't know what that is, develop urinary tract infection. Do you have an idea of what that percentage might be, what antibiotic you might start with before lab comes back, and for how long?
Question is about UTI after Foley catheterization. I don't know the percentage there. I do know that that group would fall under asymptomatic bacteria, so even if I would avoid testing in the absence of symptoms post-Foley catheter, in our region, our E. coli is quite sensitive to first-generation cephalosporins, so one of Jim Leggett's big pushes was to get around and tell people Keflex is just fine in our region for empiric therapy, and I think that's what I would use in the absence of culture data in a patient with symptomatic UTI after a Foley. For simple cystitis, 3 days is more than adequate. Cortland?
My question, you guys talked about a lot of the work that you're doing in the hospital and in the region. Thinking about all the antibiotics that are used in our ambulatory setting, is there a PPMC group like yourself that are ambulatory users?
Yeah, Dr. Childers is asking about outpatient stewardship, and that is the next frontier. And in fact, CMS has mandated that we have programs by 2021 for outpatient as well. So clearly our efforts have been primarily inpatient currently, but we are tasked with expanding this to the outpatient realm, which will be a completely different game, but one we're kind of excited to see how it'll go. Yes, last question, I think.
What's your current recommendation for surgical total joint prophylaxis?
For total joint prophylaxis, Brent, do you know what our... Yeah, we're using cefazolin just like we're doing for any other surgical procedure currently, unless patients are known colonized with MRSA, in which case I think the surgeons have a protocol for decolonization prior to surgery.
Great, thank you guys very much.